Now the next speaker is Jamal Hoballah. He will talk about the effect of the surgeon and the hospital volume on outcomes of 3E RX. Does it make a difference?
Thank you for your introduction. My topic today is a controversial topic about the impact of surgeon and hospital volume on the outcomes of abdominal aortic aneurysm treatment. Have no disclosure. Well, the operative volume has been identified as an important predictor of increased morbidity and mortality following multiple complex surgical operations in general. But its role in aortic aneurysm surgery is what I'm going to be discussing now. The first paper on this topic was done more than 20 years ago and really showed that open aortic surgery in high volume hospitals had lower mortality compared to low volume hospitals, and when performed with high volume surgeons they had lower mortality than low volume surgeons. And this was compounded, so you find that high volume surgeons doing their procedures in high volume hospitals has much better results than low volume surgeons doing them in low volume hospitals. Now, further studies were done to see on what is the threshold, and it was found that for the hospitals they needed to be doing at least 43 open elective repairs and more than 15 ruptured repairs to have improvement in their to be classified as having higher outcomes in their procedures. Now, how about the threshold in surgeons? Well, the studies showed that surgeons who are wishing to perform these type of open aortic surgery should at least perform at least a minimum of 13 open aortic surgeries to have better outcomes. Now, with the performance of introduction of EVARs, this topic was revisited, and in the studies here, it was found that the open aortic repair, you continue to have significant improvement in the reduction in mortality and with higher institutional volume as well as higher surgeons volume, and the surgeon volume had a greater mortality impact on the reduction than the institution volume. However, for the EVAR, neither the institutional volume nor the surgeon volume influenced the mortality, which is a very interesting finding. This was further elaborated and documented, confirmed in a larger study including more than 120,000, and you can see here that as the surgeon volume increased with open surgery, the mortality decreased, and as the hospital volume increased, the mortality also decreased. However, for EVAR, this did not occur. Again, these findings suggesting that open surgery should be concentrated in hospitals and surgeons with high volume, but that did not apply for the EVAR. So, is there a minimum threshold? Well, looking at the data from the national inpatient sample, they realized that EVARs performed by surgeons who performed less than one case per year had at least 36% higher odds of mortality compared with the rest. And for open aortic surgery, surgeons who performed less than 4 ERs per year, they had 41% increase in odds of mortality, in concluding that at least one EVAR case per year and 4 open aortic cases per year is the threshold associated with improved patient outcomes. Now, how about for ruptured aortic aneurysms? Again, for ruptured aortic aneurysms, it was noted that a high institutional volume will result in reduction of perioperative mortality following open aortic surgery for ruptured AAA. However, and that this perioperative survival is more pronounced for open surgery compared to EVAR. So again, this applied for the ruptured aortic aneurysm. What are the society guidelines? Well, society guidelines of the European Society for Vascular Surgery is that abdominal aortic aneurysm repair should only be considered in centers with a minimum yearly caseload of 30 and should not be performed in centers with caseloads less than 20. How about the SVS? Well, the SVS says in addition to that, it at least had a lower case threshold, but specifically looked at the documented mortality and conversion rate, that it should be less than 2% in EVARs and less than 5% for open aortic replacement, but it should be in hospitals that had at least performed 10 EVAR per year and 10 open aortic per year. Now, what if we apply these SVS guidelines and see what happens? If you apply these SVS guidelines, we found that the centers that met the SVS guidelines for open aortic surgery were associated clearly with improved 1 year and 30-day all-cause survival. And in addition, they identified that the surgeons need to be doing at least 7 procedures, and in these hospitals with less than 5 that had less than 5% mortality. How about the surgeon's experience? Well, this study looked at the surgeon's experience and classified them as those surgeons who had less than 5 years experience, those that had 5 to 10, 11 to 15, and greater than 16. And sure enough, it was found that increasing surgeons' years experience correlated significantly with reduced risk of developing post-operative complications, including mortality. However, surgeons within their first 5 years of practice were found to be exposed to greater proportions of non-elective cases and have similar outcomes after these repairs compared with surgeons with more experience. So the experience alone doesn't count, and the volume was very important. Now, how about the use of assistant surgeon? Well, this is a study looking at this important concept that lower volume surgeons more frequently use assistant surgeons. However, when you use these assistant surgeons, whether they have high volume or low volume, that was not associated with improvement in the mortality. And even the help of a high volume assistant surgeon may not mitigate the detrimental effect of a low volume surgeon. Now, how about internationally? How do these data compare internationally? This is the International Consortium for Vascular Registries, and again, it showed that for open aortic surgery, as the volume increased, the mortality decreased for intact as well as ruptured, but that did not work out in the EVAR patient. These are our results from the American University of Beirut, and we are a low volume center. We're not a huge volume, so we do at least 7 open and about 4 EVAR, but we are doing that with 2%, less than 2% mortality for the open and 1% for the EVAR. Now, how about, not all open are the same. It was found that if you did more than 4 juxtarenal, this is the number of juxtarenal aortic repairs that are really going to impact your results. And if you did more juxtarenals, then your open results will be much better than the other ones. How about ruptured AAAs and referring them to regionalized center? This is, they referred those that came into community hospital versus regionalized center, and they identified the mortality rate in the regional center, the medical centers, were 20% lower, and the transfer did not impact the mortality in of the EVAR that were transferred. So the care of ruptured AAA should be centralized, the recommendation in the US, to centers equipped with technology for both open and EVAR. So in conclusion, I think the impact of surgeon volume and hospital volume on open aortic surgical repair is very well established. The impact of surgeon volume and hospital volume on EVAR is less pronounced, and the regionalization of care and combined expertise should be considered, especially for open AAA surgery, be it elective or ruptured, in countries where the overall annual volume is low. I would like to remind you about our PAVSS meeting in Riyadh in 2 weeks from now, and please save the dates for 2024 also in December. Thank you very much for your attention.